I'm Matt Dancona, I'm an editor at Tortoise, and the pandemic has taught us many lessons about new threats, but also made long-standing problems clearer than ever, and none more so perhaps than inequality. You know, it's interesting to think back to last March, when it was rather lazily said, I think, that COVID would be a great leveller, but nobody seriously claims that now in January 2021. So the question is, what lens or lenses should we be using to bring greater equality to healthcare, and in the phrase of the moment, to level up access geographically across ethnic groups, gender, class, and so on. It's really a problem of dizzying scale. So we're very lucky to have three terrific speakers to help bring some focus to it. And of course, hoping that you will join in with gusto, and Zav Greenwood will be looking after the chat. Please do chip in with any thoughts and ideas. Hi, Zav. So let me, without any further preamble, go to one of our speakers, Dr. Halima Begum, who is director of the Runnymede Trust, amongst many other distinctions. And I suppose, Halima, what I wanted to begin by asking you is, you know, the very obvious question, which is, when we're looking at the question of health inequalities at this particular moment, but more generally, whether it helps to try and sectionalize different kinds of inequality, or whether it's a better approach to prioritize inequalities and to try and build a kind of system where you are saying, right, the first most important thing, for instance, is we look at socioeconomic inequality or racial inequality or something like that.
Thanks, Matt. Yeah, I mean, it's a question that preoccupies us this week, has preoccupied us for 10 years or so, and there's been a lot of research around, you know, how you tackle the overall health system. Do you look at groups that are at risk and vulnerable and try and support those groups to kind of get into a position of better health, or do you look at the universal health system? So I think there's a really long tradition around looking at what is the best way to improve health outcomes. Do we go for a universal approach, or do we look to prioritizing those groups that are most at risk? Now, we're dealing with a pandemic at the moment, so none of these questions that you're throwing at me can be isolated from how we're actually dealing with the current crisis at the moment. So let's take the example of the vaccines. We've known for a long time that Black and minority ethnic groups have been disproportionately impacted by COVID. As you said, that whole discussion around leveling out, really, let's just put it to bed now. We know that certain groups have been more affected than others. So the natural public policy response intuitively would be to prioritize those groups that have been most affected and are most at risk. I think we've accepted that elderly groups and people who are in care homes have been at risk of this pandemic more so than others. And we shifted resources to reflect that. We shifted public policy to reflect that. But in terms of our response to Black and minority ethnic communities, I'm afraid we haven't shifted our public policy response towards protecting those groups. So fundamentally, I think we're still asking the question, with the rollout of the vaccination, for example, would you not prioritize vaccinations to places where there are greatest need? And these happen to be urban areas, high density areas, and obviously care homes and with elderly households as well. And we are literally seeing people die in a day by thousands now, and predominantly BME groups. So we've just launched a campaign last night to push out to all of our communities to ask them to take the vaccine confidently. There's an issue around a lack of confidence there, but that issue around a lack of confidence is nowhere as big as the issue around a weak infrastructure to roll out the vaccine to get to our communities as and when we need it. So there's a massive issue there. And I think COVID, as you know, has laid bare systematic inequalities that relate to how different groups in the UK access health. And racial groups, religious groups, all sorts of other groups will have challenges, but also women as well. So women and BME groups face those intersectional challenges. And I suppose the one example to illustrate those health inequities is with the maternal health figure, right? So Black women are more likely to die from childbirth. Right, so I mean, that is a killer statistic. I mean, some of those statistics, for those of us who work in global health, for example, will know that certain countries that have very weak systems, health systems, have high maternal mortality rates for poorer women. But I don't expect those rates to occur in the UK, where we actually have a solid NHS public health system. So what is happening in the UK when we have such devastating killer statistics around the death of Black women at childbirth? And I think that says it all. So I'm looking forward to that conversation with experts that you have with us today to figure out how we can get a better accelerated health response for those that are more at risk.
Can I just press you on that, Philippa, because it's such an interesting case study. I mean, I know the session isn't about the vaccine or COVID specifically, but it is kind of a parable, isn't it? Because the data from the ONS and elsewhere on the disproportionate toll on ethnic minority citizens of COVID is absolutely inarguable. You know, it's as robust as you could want. There are subtleties within it, but the overall picture is clear. And yet, the Joint Committee on Vaccination and Immunisation, JCVI, which chooses these priorities, has kind of edged away from it in its discussions. And so there's a big policy decision to be made in the very near future, which could have a huge impact upon this particular question. So I suppose the question I want to ask is, where do you locate particularly that structural problem in the system? Why is something as obvious as this so difficult to get through? Is it in the end a political fear of something which might be seen as, you know, political correctness gone medical, or what?
So it's interesting to look at how other countries look at their vulnerable groups and their groups that are most at risk of COVID. So because they don't have this racial kind of scenario where the group that's predominantly affected is of a different racial background, they can kind of deal with this pandemic, I think, more comfortably. Whereas in a majority white country where the disproportionate numbers are in BME communities, where we've historically faced a lack of confidence with those communities, I think there is a lack of confidence on behalf of government to want to shift towards a policy that would target those groups that happen to look different from the majority of white people in this country. I fundamentally think that's the problem, because if this was a gender issue, for example, if we knew that more women were affected by COVID, I think it'd be pretty straightforward to shift resources and a public policy response that would target women first. I think that would be straightforward. The question we're asking is, well, why haven't we managed to shift public policy response to BME groups? And I do think there's a lack of confidence on behalf of the government and our leadership to do so. We're very comfortable, by the way, to talk about Black and minority ethnic communities and their lack of confidence in the system, or their lack of confidence in taking the vaccine, for example. But we're not very comfortable to talk about our lack of confidence as a leadership group to prioritize resources to groups that need it most, because they happen to look different from the majority of white people in this country. Now, I think we need to get beyond that discomfort, because we're talking about saving lives. We need to get over this discomfort. And if we know one thing from the murder of George Floyd, is that the way we discuss anti-racism, or the way in which we prioritize groups that are different from us, has to shift. And surely now is the time to shift, to try and save lives and actually get those vaccines targeted to groups that need it most. Elderly groups, people in care homes, and BME groups across all ages, Matt. I mean, we're launching a campaign actually at 5 o'clock this evening to push our communities to take the vaccine, but that's not all the story. Our communities want the vaccine too, so the rollout and the implementation of the vaccine is pretty slow as well. And we know that it's a pop-up system. So we can't have the Prime Minister yesterday talking about the reluctance and the hesitancy in some of our BME groups, but not acknowledging that maybe there's a weak infrastructure out there as well, or not acknowledging that there have been historic cases of structural racism in the health system that has stopped some of our communities from going forward and wanting treatment. And of course, these health inequalities relate well beyond COVID as well. So this isn't just about COVID, it's about the way in which the health system relates and interacts with different groups in this country, and it hasn't always been equitable.
Yes, I think that's very true. And the vaccine hesitancy of ethnic minorities has absolutely nothing to do with the anti-vax movement. It's always important to stress that, I think. Can I turn to Stuart, please? Stuart McDonald, who's the head of demographic assumptions and methodology at Lloyd Banking Group, and therefore terrifyingly well placed to fill in this landscape for us. Stuart, can you with your data hat on and analytical hat on, give us a kind of quick tour d'horizon of how you see the health inequality landscape, and where, given, taking into account what Halima said, the kind of the pressing nature of character of the times, where we should be directing our attention usefully.
No, of course. Thank you, Matt. So, yeah, as you said, I'm an actuary at Scottish Widows, which is part of Lloyds Banking Group, and I'm responsible for financial assumptions about the health and life expectancy of our current and our new policyholders. I'm also an executive on the continuous mortality investigation. So we're the part of the actuarial profession that has spent the last 100 years compiling statistics on mortality and sickness rates across society. And last year, I co-founded the COVID-19 Actuaries Response Group to learn and share insights about the pandemic. So at Scottish Widows, we've got a 200-year history helping our customers plan for their financial future with pensions, investments, life insurance, and critical illness, which gives us a real bird's eye view, actually, on trends in claims and what's going on in the data. So we saw last year a 22% fall in critical illness claims, which is way outside normal variation that we'd expect. We can see that fall is a direct consequence of a fall in diagnoses. And so we've conducted research to understand why people aren't getting diagnoses. And the most common reason for delaying or not booking appointments is not wanting to add pressure on the NHS. We're really concerned about the story that data tells us. For example, claims on nearly every type of cancer are significantly below expected levels. And it really helps us understand two things. So people are being diagnosed later, or worse, they're not getting diagnosed at all. And this is really a ticking time bomb, which is going to ultimately add more strain on healthcare services, which do not have a lot of redundancy in the system to catch up. And that's going to place a lot of financial burden on affected families as well. Now, our research is suggesting that the impact of these delayed treatments and misdiagnoses will not fall unequally on society. So 1 in 4 people would not feel comfortable having a video or a telephone consultation with a health professional. And the groups with those concerns are the groups who are disproportionately going to belong to disadvantaged and at-risk groups. Yeah. You asked about where we were as a society at the start of the pandemic, and as will be clear to the other panelists, I'm sure, and most in the audience, we were already a society with considerable health inequalities. The gap between the life expectancy of the richest and the poorest was 7 years for women and 9 years for men. Life expectancy was going up overall, but for the poorest group of women, the poorest 10%, it had actually fallen in recent years. Now, the gap between healthy life expectancy between the richest and the poorest was significantly wider still. That's 19 years for women and 18 years for men. So the poor aren't only living much less long, they're also spending an extra decade in poor health. We were giving this topic some more focus than perhaps had historically been the case. We had the Marmot Review 10 years on, the All-Party Parliamentary Group for Longevity, and a new government goal to give everyone 5 extra years of healthy, independent life by 2035 and narrow that gap between the richest and the poorest. But unfortunately, health inequalities were still widening. As you noted, Matt, we said early in the pandemic, the government said early in the pandemic that the coronavirus might be a great leveler, but they really quickly came under fire from a lot of corners for that claim. And while it can be, any of us can be infected by the virus, some groups are much more likely to encounter it, and other groups are much more likely to suffer serious consequences if they become infected. And worryingly, there's a big overlap between those two groups. It's become very clear in the last 9 months that the pandemic is at least perpetuating and almost certainly exacerbating those existing health inequalities. And at the very least, it has laid them bare and really opened up the discussion in a way that was less public before. Go on, Matt, sorry.
What I was going to say, sorry to interrupt, how easy is it for a system as centralised and founded upon the admirable principle of universal healthcare to target treatment, because what's already emerging is a picture of needs focused in particular areas, not geographic perhaps, but demographic. How nimble is the NHS in this regard?
I'm perhaps less qualified to talk about the functioning and of the NHS than others here. But whilst we do have centralised policy, there's very localised implementation of that, and each level of government essentially passes off guidance to the next level down until it reaches primary care networks, and there's inevitably significant heterogeneity, a lot of variation across the country in how policies are ultimately implemented, and we can see that with things like the vaccine uptake that's already been discussed. So we would expect inequalities in vaccine take-up by age, sex, ethnicity, and socioeconomic groups. And Dr. Begum's already touched on the concerns about ethnic minority groups perhaps being less likely to accept the vaccine.
And coming, if one sort of accepts that whatever happens with the vaccine rollout in terms of the government's targets, that it is in one shape or form the basis of some sort of exit strategy. What do you think as we sort of emerge blinking from this great experience will be the first big health inequality issue that confronts the government other than COVID itself?
Well, I think there's a few points to pick at there. So firstly, I think the vaccine is going to is no panacea, and whilst it gives us light at the end of the tunnel, it's going to be some time before we can safely emerge from this pandemic. So interestingly, I mean, through all of this process, we've seen a certain predictability. We could see case numbers, then we could follow hospitalization numbers, and then deaths. Interestingly, the vaccine is going to reverse some of that. So we're going to see death numbers fall first. That's where we should get benefit because of the way it's being prioritized and targeted at the highest risk groups. We should see death numbers come down considerably. So my group's estimated that compared to a counterfactual scenario where we didn't have a vaccine, we should see an 88% reduction in deaths. Hospital admissions will fall more slowly, and pressure will ease up on intensive care units last of all, and that's likely to become the pinch point, and it's going to be some time, I think, before we can safely emerge from this pandemic. But I absolutely expect that the debate will heat up in the months to come, because while we see very significant numbers of deaths and hospital admissions that most in society would find unacceptable, that clearly puts pressure to perpetuate the current lockdowns and social distancing. But as we start to see those measures ease off, that pressure may well ease, and certain groups will begin to apply real pressure. So I think, going back to your question, the vaccine uptake is very likely to be one of the issues. I think long COVID is going to be an issue where we see considerable inequality. So Dr. Bacon touched earlier on about, if there was a gender issue, we'd be quick to address it. I think there is a gender issue here. Women are significantly more likely to encounter the virus. So if you look at the professions that require you to be up close and personal with people frequently, so healthcare is a classic example. You're looking at 3/4 of people in those occupations being women. But then conversely, men are much more likely to have a serious adverse reaction to the virus, so and suffer from serious disease. So, but going back to that first point, I think we may see disproportionate incidence of long COVID in women, for example, once we've got this immediate issue of hospitalizations and deaths behind us.
Yes, and of course the way in which it's treated will no doubt vary hugely in terms of healthcare access. On which note, can I thank you very much, Stuart. We'll come back to you. Can I turn to Dr. Philippa Whitford, who is known to everyone who's interested in healthcare in and around Westminster and far beyond. Not only as the Shadow SNP spokesperson on health and social care issue, but also as a distinguished clinician herself. Philippa, can I sort of, in a way, throw the question to you in a slightly reframed way, which is, we're starting to accrue already in this session a list of inequalities. And I mean, I'm intrigued how you see it both as politician and practitioner. Do you think that the answers lie in structural reform, or in a combination of that and an improvement, if you like, in health literacy? Because one of the great inequalities I see is that there are people who for one reason or another, achieve a great deal of knowledge about their health and how to improve it, and they can afford to improve it through nutrition and other means, and others who don't. And I'm just fascinated by someone who has the experience of being in touch with constituents, but also, working at the sharp end of medicine, how the two converge.
Well, I think there are multiple inequalities, and I think it will take multiple different approaches to tackle them. So to me, from kind of my experience, I mean, both reading and at the front line, if you like, there's four main inequalities: gender, which has been mentioned, the deprivation and poverty, racial and ethnic. But the one that hasn't been mentioned so far is around disability. So I see it as four major groups. And you have issues, particularly around the ethnic community, the deprived communities, of what's called the inverse care law, that the NHS tends to respond to demand rather than need. So you may have more GP practices in the leafy suburbs, and you may have fewer practices in crowded inner cities with more poverty, more comorbidity. And it's important to remember that individuals may actually be in all of those groups. It may be a Black woman who is disabled and living in poverty. And what we have seen with COVID, obviously the impact on ethnic communities, but particularly also the deprived communities. And some of that is the inability to afford to work from home, or not having that kind of job, having an exposed job, having an insecure job. And also people within that community not isolating or not even coming forward for a test, as we saw in Liverpool. So the inequalities were already there. And the problem is that COVID has exacerbated them and added on top of them. And I think you've got two different approaches that you have to take. And some of that approach is the NHS. There needs to be a lot more partnership working with a community, not just people sitting and deciding what they think the solution is. So you need to engage in a partnership fashion with champions and leaders within the disabled community, within ethnic communities, within deprived communities, to actually hear what is it you need, what is it would work. But the other thing is that COVID, in so many ways, has shone a bright light on the weaknesses in our society. We're talking today about health inequalities, but the UK is just simply one of the most unequal countries in the world. And, when we look at the rise in poverty over the last decade, the increase in child poverty, disabled poverty, pensioner poverty, unfortunately, this pandemic hit at the end of 10 years of austerity. So people were poorer, people were in more insecure situations, and people were more vulnerable, but also health and social care had faced such cutbacks for 10 years that it was, just not in a position to make a good response. I mean, if you look in England, 43,000 nursing vacancies, 100,000 staff vacancies overall. So you were talking about a system that was struggling to cope with normality, and then suddenly was hit with a pandemic. And obviously it's the same NHS that has to deal with COVID, try to encourage people to come forward if they have a worrying concern, whether it's chest pain or a lump, seek help, but also to get out there and vaccinate. And that's why for all the rest of us, it's absolutely critical that we play our part in driving these cases down. And my worry is that the Prime Minister and the UK government are already talking as if this is over because of the vaccine. You know, even in the debate on introducing lockdown in England, there was already the kind of hint as if, well, once we've got the top 4 vulnerable groups vaccinated by mid-February, we'll start thinking about that. Well, what about the other 5 groups that have been defined by age by JCVI? That's even before you come to the second wave of vaccination and start looking at people in key worker jobs, Black and Asian minority ethnic groups, people with other comorbidities. So the idea that somewhere at the end of February, you could ease off this lockdown, you will have the same experience as Israel and you will have a huge surge. So I think we need to keep the vaccine in a kind of reality position, which is you don't achieve herd immunity even on the original virus until you have vaccinated over 60% of the population. And for the new variant, it's probably higher. And what we do not even know yet, and that influences your vaccine strategy, is do the 2 vaccines we're using prevent transmission? Because herd immunity means the vaccinated are protecting the unvaccinated, and we still don't know that. So the problem is, it's brilliant, it's light at the end of the tunnel, but vaccines are not a magic wand, and I fear that the UK government are about to make the same mistake they have already made repeatedly in the last year, which is to keep flicking between an emergency public health response and a let's all get back in the pub and spend money economic response. Whereas if you look at the countries that have done well, it's the ones that accepted this right at the beginning, have driven down the virus, taken a zero COVID approach to the virus, and while they're now controlling their external borders, internally, places like Taiwan, Singapore, New Zealand, they're all out in the pub and the restaurant. They may not be going on international holidays, but their domestic economy is up and running.
Absolutely fascinating. Can I ask you a follow-up question, which is, I mean, Stuart lit upon a very interesting point, I think, which is a reluctance amongst people to go and seek medical treatment that has become much clearer in the last 10 months. Partly, one suspects, out of a combination of an altruistic desire not to burden the NHS at the moment when it's overstretched, but also fear of picking up the virus in the case of those who are clinically vulnerable already. And on top of that, yesterday I got a text from my own GP's clinic saying, essentially don't come in, patients, but if you want to tell a consultation, book it here. So there's a lot of push away, and I wonder if you think that the impact of that will be long lasting, it will breed its own habits of caution amongst people in taking advantage of the health services which are available.
Well, I think there is a big concern about that, and the drop off during the first wave and people presenting with chest pain, people attending with possible cancer symptoms was very worrying, and very quickly then, certainly here in Scotland, our chief medical officer was very much pushing, the NHS is still there, the door to your doctor surgery may be shut, but they are behind it and they're there to help you. So, dial the normal number and they will take things forward. But it could increase that inequality. I mean, particularly using the system that we use in Scotland, I don't know if it's the same in England, called Near Me, which is video consultations. Well, what about the people who don't have access to a computer or an iPad or the internet or are not digitally literate? And all of these things always overlap with the same group. So there's definitely the risk of this deepening the inequalities. But a lot of it comes down to outreach and partnership. So I'm a breast cancer surgeon, and I was the lead for breast cancer screening for South West Scotland. And one of the projects that we did when we realized that we were getting much poorer attendance at breast screening in poorer communities than we were in middle class communities was we started using our mobile systems more. Now, Scotland's 1/3 of the UK. One of our big challenges is rurality, simply covering the ground. So we have huge mobile screening vans that were being used to rural communities. But actually, when you turned up in a village, the uptake was like 85% of women would go and get screened. But in cities, it was a fixed unit. And what you found was poorer women weren't attending. So one of the projects in Scotland was to say, well, actually, let's take the vans and go and base them in supermarket car parks. Let's actually go into big housing estates. And that did drive up the attendance. So some of it is practical things around access. Some of it is around health education. We're not a great country for educating our children and young people in the important knowledge of health when they're older, and that's something that we need to tackle. But we also need to make sure that we are dealing with practical and cultural barriers. I mean, one of the ones around disability, the symbol is a wheelchair, and therefore people often think it's about mobility, right? Okay, we've got a ramp, but how does someone get into a scanner? How does someone get onto a couch? But how do they even get there in the first place if our public transport is so unhelpful to people with a mobility issue? And what about the other forms of disability, sensory loss or learning difficulties? I mean, one of the striking things, BSL, British Sign Language, is an official language in Scotland. So we have had a translator behind the First Minister in every single COVID briefing, which happens virtually every day, right since the start. Not in Westminster. I raised it in Parliament. You see one of the TV channels adds it, but why is it not there in the first place? We heard in some of the northern cities that had huge outbreaks that COVID regulations and advice weren't being translated into the local languages. So, some of these are not rocket science. Why are we not making the effort to actually do them?
No, it's very true, Philippa. Thank you. Can I come to Sarah Bainbridge now? Sarah, are you there? Hi, Sarah. Sarah is the Head of Policy and Influence at the Macmillan Cancer Support, and obviously brilliantly qualified to discuss some of the issues we've been talking about. So, Sarah, can I just ask you straight up? I mean, what are you noticing on the ground? Very worrying figures that Stuart mentioned earlier about people seeking diagnosis, and then we know about the many cases of cancelled treatments and so on. What does it look like? What's the lie of the land? Oh, we can't quite hear you. I think you're still on mute. Nope, still. If you press the unmute, have we got?
That better?
That's better. Yes, yeah.
Great.
There you go. Hi, Sarah.
Sorry. So, as has been touched on by all of your panelists so far, cancer care has been impacted by this pandemic, but it's also building on pre-existing inequalities that we were already aware of. So I think the first thing, as you've alluded to, is that there was an enormous drop in people contacting their GP in April, and we think that was an unintended consequence of the stay at home and protect the NHS message. And we've really been flagging the fact that tens of thousands of people potentially might have cancer, but haven't yet entered the NHS to get the tests to diagnose that, and so won't have started their treatment. But what's really concerning is that there may be inequalities in who is now coming forward and who is comfortable in actually saying, yes, I'm happy to use the NHS. So it might be that older people aren't comfortable in contacting their GP. We've also seen a little bit that women might not be coming forward. We already knew that people who have Black, Asian or another ethnic heritage, or who are more deprived, often lose out when it comes to early diagnosis of cancer. So I think what's important is understanding the picture, capturing all of that data, but then going beyond those descriptions and going to interventions. So I think there are messages now saying the NHS is open, help us, help you, come forward. But as we've already alluded to, that's got to be translated into other languages. It's got to be put into people's homes in a way that they're going to see. So let's not assume that people are scrolling through social media and will see things on Twitter, but this has got to be advertised on your sort of Saturday night television programs. And I think the other thing to say is that we have to make sure, as Dr. Whitford alluded to, we work in partnership with communities and make sure that people know that the NHS it is there and open for them. But I think all of that is, going to be putting more demand on the NHS in a time when we know that, as you've said, there are disruptions to cancer care. So I think the other point is the NHS has to be resourced sufficiently to make sure that we can catch up with the disruption that the pandemic has caused. And we can't treat people equally or improve inequalities unless we have more staffing. There is a big nursing gap, as we've already mentioned, and we need to make sure that we've got a long-term, fully funded workforce plan for the NHS, because there's no way we can catch up on any of these inequalities if we're struggling with an NHS that is short-staffed. So I definitely say that there's things that can be done now in the immediate term, but also thinking ahead for the future. We've got to make sure that the NHS is fully staffed, but also that the interventions we're putting in practice now, so more phone calls for people rather than assuming they'll have a video phone call with their GP, that might suit people from different parts of the population, rather than just defaulting to what perhaps a certain subset of the country would feel comfortable with.
And Sarah, to what extent do you think that when the situation becomes somewhat more easier and restrictions are relaxed, are we facing, as it were, not to be glib, but kind of an oncological credit card bill of huge proportions, that there will be people who discover that they are much further advanced than they feared, people who could have taken treatment during the pandemic haven't? I mean, how big is this problem?
It's a really difficult question to answer. We know for sure that we've seen a big difference in the number of people diagnosed in 2020 compared to what you'd expect. So it's tens of thousands of people. What we don't know is what the impact of that will be. So cancer is time sensitive. We have to recognize that if you catch someone with a tumor, for instance, that's very local and hasn't spread, that's much easier to treat, likely to have a good prognosis for someone. If some of those cancers aren't treated, if people's surgeries are disrupted, if people who are living with cancer have scans that aren't checking on the progress of their cancer, all of that will add up, but we just don't know yet what the overall impact will be. And I think, as I say, to make sure we've got a fully resourced NHS that is prepared for the fact that there will need to be more activity, both in diagnosing people, in treating people, and also potentially, sadly, in people who might just be living with treatable but not curable cancer, and so will need really good palliative and holistic support. But I don't think we have a kind of magic number yet of what exactly the long-term impact on people with cancer is going to be.
Clearly something for us to monitor and something we're very interested in, Tortoise. Thank you, Sarah. Can I come back to Halima, who I think had some comments on the remarks we've heard? Halima, hi.
Hi, Matt, thanks. I just wanted to pick up on a few comments that have come up between all the panelists, and what is, I think, a discussion happening outside of this session as well around what are the reasons why we have these health inequalities. So Professor Michael Marmot and others have for 30 years talked about what they call the social determinants of health outcomes, inequities, and so on. And by that, they mean the social and environmental conditions in which people live, work through their lives affects their health outcomes. Now, that necessarily means that the situation is structural. So far, we've been relying on the public health system and medics and scientists to figure out how to fix either the pandemic or the underlying health issues that we have facing us. But if you accept that some of those factors are structural, then I think there needs to be a different discussion around how we resolve the health crisis. And I would also add, and maybe that Michael Marmot and others hadn't quite surfaced that out, some of those socio determinants are also to do with race, for example. So we would add the kind of racism factor in there, in addition to socioeconomics and environmental factors. Now, if that is the case, I think we need to now go back to that point that Philippa made around an NHS system that seems to be built around demand. You know, those that demand it more will get the services, as opposed to where the need is greatest. I think there's a piece missing here in your analysis, Philippa. Yes, we know that middle-class people tend to demand more, and they get more because they have a more confident voice. But equally, I would say that the supply of NHS care it's not good enough that it sits in that passive way and doesn't think about matching that to the need. Now, if we're saying that the need is greatest in areas with high demographics of people who are sick, naturally a public policy response needs to shift towards there. So yes, there's a supply piece and there's a demand piece there, and that's basic economics, but I think it's a role of politicians and decision makers to think about that sweet spot around need and where the need is greatest. And that's really important, Matt, because we're having a discussion as though, well, here's the medics, here's the politicians, and Michael Marmot and others have talked for decades now around those social and environmental factors. We are now also discussing the racism elements to it. So we can't really have a conversation around health inequalities and equities without that conversation around race and the intersectionalities. So I thought that was really, really important to point out. Philippa, you also said that the vaccine isn't the answer. It's not the panacea. Government may well decide it is a panacea. Government's approach has been lockdown A, B, 2, and off we go, we'll go back to normal. Let's get the vaccine out, we'll go back to normal. But you know what? I think the public on the whole has understood that these are not short-term fixes. The public has understood that behind the COVID crisis, we can see that the whole system needs uplifting. So I feel quite hopeful that the public understanding of what the health crisis is now that much richer, and we can actually hold the government to account. So let's redesign a better health system that feels more inclusive, that feels more bottom-up driven, and designed not to serve those that can just demand better because they have the loudest voices, but it actually can be matched to the need. And I think COVID shows where the need is at the moment, and we just haven't got there. We haven't followed the need. I think that's a fundamental ethical principle that we need to follow.
Thank you. Can I come to Ben Cropper now, who made a very interesting intervention on the chat? Ben, are you there? Hi.
Yeah, I'm here. I just wanted to ask the panel, really, what can be done to avoid the mental health postcode lottery we are now currently experiencing? Because I'm a disabled person who's been forced to shield during the pandemic due to vulnerability to the virus, and I have several peers in different areas of the country that have much more easier access to mental health resources than I have in my area. So the postcode lottery is always going to be a thing with healthcare, but particularly with the long-term effects of prolonged shielding in mind, I wondered what could be done at this juncture to try and mitigate the consequences of that.
Thank you very much, Ben. Philippa, would you like to answer that? And I know you had some points you wanted to make as well.
Well, I mean, I think what underlies that is the long-term fact that mental health was very much seen as, secondary to physical health. And, I think that until we really tackle that, there's been a lot more openness about mental health issues, mental illness, and the need to tackle it within Parliament, but we've not actually seen it move up the agenda in a genuine funding way. And because things like staffing within the mental health segments of the NHS are so far behind, it's not just the money, you actually have to train people up, and therefore you need to be investing in that in a very positive way to try and bring the importance of mental health up to parity. Parity of esteem is what is talked about a lot, but we don't see the reality of the commitment. But also when you reach that point, it will still take time to turn around. And obviously then that does result in, if you are in an area that you're lucky enough to have, that there are some innovative projects or the staffing is quite good, then the service may be much more responsive. And if you're in an area where they're struggling to recruit people or, even replace people who've retired, then the service starts to crumble. And, one of the things, it was just also to come back to what Dr. Begum was saying, as I said in my opening remarks, you've got the two sides, which is what the NHS has to do to reach out and not just invite, but actually pull people towards the service who have more need. But the other thing is the underlying social structure. These issues of minority communities, poverty, deprivation, or how disabled people are marginalized, these are not just NHS issues. These are society issues. And, you know, things like child poverty was falling. And the change where we saw all poverties, disabled, pensioner and child poverty rising, wasn't the crash of 2008, which is what you might have expected, but it was the welfare changes of 2012. And what we've seen is that take off in all these different segments. But there are things that you can do about it. I mean, obviously, your slide talks about maternal health, but the other one that we use a lot in developing countries is infant mortality. And actually, infant mortality had been falling, but has actually been rising, particularly in England. In England, it's above 3.8 per thousand live births. In Scotland, because of the early years collaborative that took an absolute focus on trying to drive down child poverty, we've seen that fall to 3.2. But again, this comes back to, you know, recognizing these problems and putting energy into some of them. But as I said right at the start, you will have people who are in all of these groups. You know, people who are Black and Asian, minority ethnic are more likely to be at the poorer end of the scale, to be in insecure work, to be in exposed work as key workers, and therefore more at risk of COVID. Disabled people, as we heard, are more likely to be shielding, more likely to have underlying comorbidity. That means if they get COVID, they're going to get more ill from it. But COVID, I think, is just shining a very bright spotlight on problems that have been there for decades. And we do need to think about what kind of society and economy are we going to go back to. It's not all just going to recover by itself. It will need investment. And I was part of the all-party group on health in all policies, or the well-being economy approach, which is looking at things like sustainability, looking at fairness, and actually putting physical, mental, and environmental health right up there with human rights when politicians are making policy decisions at every level, whether it's Westminster, Cardiff and Edinburgh, or your local authority. We think of health as a kind of little extra, whereas when we're making decisions about everything, we should be thinking, is this going to make people healthier, or is it actually going to have a huge cost? Because it doesn't make sense. You always end up paying for that cost later. So children who grow up in poverty will struggle in later life, and you will end up picking up the pieces. Why not invest in both these communities and these young people right at the start?
Thank you, Philippa. I'm horribly conscious of time, but wanted to go briefly to Stuart at the end, and just really picking up on some of the points that Philippa just made. And, you know, Stuart, how confident are you, as someone who has this sort of, you know, very enviable bird's eye view of it all, that what will happen after the pandemic will not just be a series of elegant sticking plasters, but will actually have if you like, a strategic dimension to it?
I think confidence is hard to find at the moment. The responses are very much still emerging. I suppose it's to be hoped that, you know, as Dr. Whitford just mentioned, public health has come up significantly, the public's agenda, and we'll have a generation here for whom that is a huge priority, and who will expect to see a strategic response to improve the facilities that are available within the NHS and elsewhere across the UK. We shouldn't underestimate the enormous cost to this. We haven't touched upon the aging population, which of course means that within the UK we have inevitably an ever increasing burden and demand on healthcare, and therefore we need an ever rapidly increasing supply and capacity to deliver healthcare across society. So, you know, to go back to your question, I'm confident that the public's priorities seem to have shifted, but I think the societal response and the government response is still to be seen. We're still very much in the tactical fixes stage, and it's to be hoped that as soon as possible we can move on to strategically planning for the future.
Thanks, Stuart. Well, I'm aware that I've already overrun my time and want to leave at least a brief cup of tea break for everyone before the next session. So I'll sum up very briefly and probably do injustice to what's been an absolutely fascinating discussion. I mean, clearly, what we've seen is a deepening existing inequalities and the revelation disclosure thereof. And what comes out very clearly from this session, I think, is the intersectional character of those inequalities. That gender, ethnicity, disability, occupation, geographical inequalities, job type, age, and the most obvious example of deprivation. They all interact in subtle ways, and they all need to be addressed in specific ways that are nonetheless interlinked. The kind of time-bound kind of theme that emerged, I think, is that as we exit slowly from the pandemic in due course and by stages, we're going to need to accept that there is a kind of reluctance around accessing healthcare. Some of that is historic. Halima talked very impressively about the reluctance around ethnic minorities, but pointed out that that has as much to do with supply side issues and access, and I think that's terribly important. And then there are the more general COVID-driven reluctances that Sarah mentioned, the problems related with cancer treatment, particularly among older people, and women being a little more reluctant to come forward, which I think is very alarming. Clearly, Philippa talks about health literacy and extending access into unexpected areas like car parks. That nimbleness, that entrepreneurial spirit that we've seen in some places during the pandemic is something I think we want to keep. And accept that though there are no silver bullets, there are some very important lessons to be drawn from what we have been through and are still going through. I remain convinced as ever that human agency is the most important part of this, and that I think Philippa used the word energy, and I think that's absolutely right. So one hopes that in the journey out of the pandemic will be informed by some of the very impressive points that have been made by our panelists, Halima, Philippa and Stuart. Thank you to them, and thank you all for joining in. My colleague, Liz Mosley, will be leading the discussion at 1 o'clock, starting at 1 o'clock on mental health. So enjoy a quick break and come back, and we shall move on to the next session. Thank you very much indeed.